Thank you. Thank you for your kind introduction, and thank you to the organizing committee for giving me this opportunity. I'm going to talk about a topic which is a theme for an entire conference, so it is difficult to concise it into 15 minutes talk, but I have tried. So just consider two examples. Ria, who is 16, stress is her constant hum. She is stressed from the home by parents, exam pressure, social media, and also a boyfriend. She has dizziness, body ache, sore eyes, sleep issues. And Arjun, who is a shadow of himself, being afraid, hopeless, avoiding school, and shunning friends. All the tests that are done by the pediatrician are normal. They are not alone. There are so many millions of them, Riyas and Arjuns in our country. And what does WHO say? That 1 in 7 adolescents, 14.3% between 10 to 9, experience a mental health condition. They often remain unrecognized and untreated. And adolescents are particularly vulnerable to so many things: social exclusion, discrimination in the society, and right up to human rights violations. Depression and anxiety, behavioral disorders are the leading cause of illness, and conduct and ADHD are other very common conditions. The risk factors are many, so many of them are facing this, and because of this, the mental issues are rampant. Fourth leading cause of death in boys and third in girls is suicide. And what does the silent epidemic in India say? 3/4 of class 12 students get less than 7 hours of sleep per day. One Indian student commits suicide every hour. There is 0 child psychiatrist per lakh population. Anxiety prevalence ranges from 23 to up 66%. Less than 1% teens receive care, and government has started 2 very important portals, Telemanas and Kiran, as helplines, but they are woefully inadequate. Only 3% go to professionals and 40% experience depression. So the mismatch is so very clear. It is often said that adolescents are moody and this will pass, but 4 to 8% have persistent sadness, withdrawal with a clinical sign of depression. Rarely seen in good families are mental health issues or in good schools, but we see so many mental illnesses in all the different sectors. Adolescents grow out of mental health issues is a myth, because untreated conditions, if they persist, can go into adulthood as chronic illnesses. Health professionals unnecessarily prescribe addicting medications, but the fact is they are safe and given only when clinically indicated. Only weak minds seek help is a very common scenario in the minds of adolescents, but actually seeking help is a sign of strength and resilience. Talking about suicide puts idea into their head? No. It opens the door for timely intervention and support. So, mental health issues are just like Wi-Fi's. When they are there, nobody is aware about it, but when they become weak, when the issues are there, then all the different areas of life are affected. So how many of us are listening to distressed mind, unusual behaviors, many somatic complaints which could be indicators of mental health issues, and excess screen time that the adolescents are devoting themselves to? So let us all listen and learn well about adolescents through a biopsychosocial approach. We have to understand this approach, treat them and refer them appropriately, and always remember that you are a part of a multidisciplinary team, and you have to adopt a multimodal approach individually for every case. So what is biopsychosocial? All of you know that there are some biological factors, social factors like family, which has been recently stressed by Dr. Ghosh. School, we have launched 2 very important modules for teachers, and also psychological issues which could be there in different types of areas in adolescence. So this biopsychosocial approach not only helps us to treat, but helps us to find out what could be the social factors for any mental disorder which can present as a physical disorder. So in OPD, we do have very simple and very usable and very quick tools which can help us to determine the red flags Dr. Shamik Ghosh was talking about. So we have PHQ-2, PHQ-9, and also I found this Robert Goodman's SDQ test very useful. This is Strengths and Difficulty Questionnaire, just a 10-minute test which can be done by the receptionist, and it can be scored by you, and this will immediately give you a very good assessment of the mental condition of the child. So it is available in all the 18 languages, also in Hindi, and everybody, even the parents, it can be done by the parents or an adolescent above 16 years who can understand it. And it is, I think these 2 links are very important, which everybody of us can do a 5-minute check. We have talked about red flags. You all know that with the previous lecture, so I'm not going into this. So what are the interventions that we can do? What are the therapeutic? Because now the mental health condition is there, at least you have some clues. So what are the things that are available with you? That has to be according to DSM-5. So you have to understand those criteria, especially for neurodevelopmental disorders, including intellectual disability, autism spectrum, ADHD, and learning disability. There is a schizophrenia spectrum, which is not our domain, but it is important to understand the early red flags so that we can refer the patient appropriately in time. So all the disorders of psychosis, and there are some which are associated with depression, mood disorders like major depression, and dysmorphic mood dysregulation disorder, which is, I think, very commonly seen in ASD and other children also. There are specific criteria for this. In simple words, the child is constantly angry and irritable, and there are more than 3 temper tantrums every week, and which are inappropriate for age and inappropriate to the situation. Of course, bipolar disorder is there. The last 2, the anxiety disorders and the stress or trauma related disorders, can be taken under our purview. They are relatively easy to treat with the skills that you have and the medicines that you have at your disposal. Generalized anxiety, panic, and obsessive compulsive. Sometimes OCD has to be referred to the psychiatrist, but at least initially you can try treating it. And PTSD. I have realized this during COVID times. I had so many cases of PTSD, and most of them I could treat. So PTSD is one, post-traumatic stress disorder, and some acute stress disorders which can be very commonly, easily treated by pediatrician with appropriate skills. Now this medical therapy is according to the disorder. So for every disorder, there is a different set of drugs. The depression and anxiety, they have SSRI and SNRI, that is serotonin reuptake inhibitor, and this serum noradrenaline reuptake inhibitors. Both of them are at our disposal and can be handled by a pediatrician. The commonest amongst them to be used is the fluoxetine, but we can also use benzodiazepines and anxiolytic short-acting for acute stress disorders. For bipolar, there are mood stabilizers. This is all just to give you an idea what are the things that are used by the psychiatrists, but many of them we may not be able to use. Mood stabilizers like lithium, valproate, lamotrigine, schizophrenia, psychosis, antipsychotic medications, chlorpromazine, haloperidol, and also risperidone and aripiprazole. For ADHD and substance abuse, again, we can equip ourselves to deal with these children because we are the main coordinator for these diseases, especially for ADHD, where we have two sets of drugs, stimulants and the non-stimulant ones, the methylphenidate group and the atomoxetine. For substance use disorder, motivational interviewing is the first step, but then for their withdrawal symptoms and other things, sedatives and anti-epileptics need to be given. So what is the non-pharmacological therapy? Again, this is a part which all of us can learn. You all know what is cognitive behavior therapy, where the thoughts are addressed so that the behaviors can be changed. The collaborative structure of this therapy is very useful because then the adolescent becomes part of the entire plan, and it can very routinely be treated. These conditions like anxiety, depression, phobias, OCD and post-traumatic stress disorder can be handled by learning the skills of cognitive behavior therapy. Similarly, there is another therapy which is rational emotive behavior therapy. It is a little more advanced and more a therapy which actually changes the outlook towards your approach to life. So it's more of a philosophical theory and has confrontational attitude in it. It is also useful for anxiety and depression. And dialectical behavior therapy. This therapy is quite useful in adolescents because it applies the principles of cognitive behavior therapy, but in addition, it gives them practical skills of interpersonal relationships, how to regulate their emotions. So these skills, like for example, relaxation techniques, all these skills are focused in dialectical behavior therapy. So these are very useful tools for non-pharmacological interventions. I was talking about PTSD. One of my patients, I was treating her for PTSD with the anti-anxiety drugs and the CBT. Then she moved on to USA, and there they started her on this EMDR. This therapy is eye movement desensitization. So where the therapist not only guides the patients on the cognitive behavior therapy, but at the same time, he guides the patient on eye movements. The concept is these guided eye movements, if they are followed by the client, it helps the brain to reprocess the distressing memories, because those flashes or the painful memories these adolescents have, they have to be allowed to stored in the brain in a less traumatic way. So this is another therapy which is useful. Then we have adolescents with ADHD, ASD and LD, and for every aspect of these disorders, we have a pediatrician as the primary care coordinator. So comprehensive assessment, combination of methods like observation, testing, screening, medical management, and even school accommodations, which we should absolutely advocate, are the part of these therapies. For ASD, we have so many developmental pediatricians, and they are taking very good care of them. In adolescents, with these adolescents with ASD, there are some more problems related to their emotions and their growth of development, for which we have to be very proactive. For LD, again, we have to advocate for accommodations in schools so that proper coordination, screening, and the inclusive therapy for these children with their individual education plans can be done with the help of the school. For ADHD specifically, we have drugs, we have behavioral therapy, and we also have social skills training, which is looked at with dialectical, that is DBT, that I have talked of. So appropriate social behaviors are taught, then the specific strategies for behavior change with task organization, time management, problem solving, and using the theories of positive reinforcement like token economy, for making their routine consistent. All of these help. So we have to have an eclectic approach where we have drugs, we have behavior therapy, and we also have some techniques for them to practice so that they tide over the basic crisis. So this is another very good approach by Orton Gilligan that is specifically used for dyslexia and dysgraphia, where multisensory learning, structured and cumulative courses, practical guided skills for these with their individual education plan, and confidence building by the teachers and the therapists like us is very important. So there are certain other pharmacological interventions for substance abuse. Here again, there is a combination of approach, behavioral therapy, as I said, and we have just listened to a symposium on various counseling techniques. So motivational interviewing is very important. There is also a therapy called as contingency management, where you have to immediately think of a short-term plan which can help the person come out of a crisis. And there are certain specific drugs for different substances that are used in the hospitals. I have found that this tobacco with nicotine patch is a very, very good intervention, even in a tribal area where I live, where we have adopted this approach to take them away from the BDs that they very commonly start taking right at the age of 5 or 6. So this tobacco use, nicotine patch, and also gums and lozenges are used for de-addiction. And there is, of course, the dialectical behavior therapy, and the level of care in the hospital for substance use could be started with detoxification, then rehabilitation, followed by OPD therapy, and there is also concept of sober living homes where they live for some time and start practicing sobriety. The support systems are very important in substance abuse disorders. As you all know, Alcoholics Anonymous, the Nicotine Anonymous, these are very professional group therapies which come to your rescue for these adolescents who have fallen into addiction. Family therapy, especially the attachment-based family therapy, ABFT, is also very commonly used in substance use disorder. For suicidality, we have crisis management, psychotherapy, and medicines. Crisis, of course, the immediate response planning, also lethal means counseling, which is done so that all the things which could harm the adolescents are taken off, and hot helplines are also. I talked about Tele, Manas, and Kiran. I have found that these are the things which we should promote, because if they are adopted by adolescents, especially in areas where there is no psychiatrist and no adolescent pediatrician, then these can help. I have talked about the DBT and CBT. CAMS is Comprehensive Assessment of Management and Suicide. Just 1 minute. And this is very useful in the immediate plan for suicide. Then we have medicines for suicidality in certain specific situations, like psychosis, clozapine, and lithium in bipolar disorder. There are some other ways. We have talked about group therapy, family therapy. There is also art and creative therapy to de-stress them. And there are certain community-based therapies like peers, counselors, community health workers, and support groups. Play therapy helps in younger children. So these could be the functioning tools for us. We have, with advent of AI, some chatbots, our own traditional cultural practices. Then we have very important 2 modules which are available on the website of Adolescent India, the Teach module and the Ahanas, that is Nurturing Adolescents in Schools, which is a self-learning module which we can promote in schools. The teachers can adopt and they can help us in maintaining a better adolescent mental health. Of course, life skill education and CSE is very important. So you remember Arjun? He became aggressive. One morning, his mom gently said to him, approach which is very important. Let us take the help of a doctor. He started crying and he wanted to come to the doctor, but he was not able to express his. Finally, what would you do? These are the things you can do. And with these tools in our hand, every pediatrician can be the first responder in adolescent mental health. We have so many things with us. Let us be ready to intervene. These are the key takeaways. All the best and thank you.